as I was just revising with the topic, I'll quickly do that and then go ahead with the second part of the same topic, that is abortion. Um, so we were discussing about the tests which are being done in the abortion. Okay, to rule out the cause of the abortion. Now, clinical types of abortion, depending on how the presentation is, there are 5 different types. You have threatened abortion, where the clinical entity, the process of abortion is just started, but it is not in a not progressed to a state where it is not impossible to recover it. So there are chances that with the proper treatment, we can revert the procedure of abortion and retain the pregnancy and continue the pregnancy. Inevitable abortion is where the process has continued or progressed to a stage where the continuation of the pregnancy is impossible. Complete abortion is the products of conception have all been expelled en masse and there is no retained products within the uterine cavity. Incomplete is the opposite of it, where partial products have been expelled and partially lying within the uterine cavity. Missed abortion is where the fetus is dead inside and it is retained inside the uterus and has not been any with significant presentation. That kind of abortion clinical type is called as missed abortion. So there are these different kinds of abortions can be identified based on the different types of clinical pictures. Now, clinical picture of all these 5 types we have discussed earlier. So it's easier to identify, also correlate with the ultrasound findings, and then the diagnosis is made. Finally, the diagnosis is made. I'll go to the slideshow mode. Yeah, so we were here. Now, another form of clinical presentation is a septic abortion, where there is infection within the uterine cavity because of the retained products of conception. It's a very extreme and important complication of septic abortion. That is the septic abortion. Then another important cause for recurrent abortions and or abortions is the cervical incompetence, where the cervix is either genetically problematic or it has a developmental weakness or it might be associated with any uterine anomalies. So the most important diagnosis for this condition is where the patient gives a history of recurrent abortions, especially second trimester abortions. So you have to rule out cervical incompetence whenever there is a second trimester or mid trimester abortions. So it can be diagnosed by within during the pregnancy by noting the presence of the funneling of the internal os, or the os being open and funneling as well. Even sometimes there will be herniation of the membranes. So this is how it can be diagnosed. Management is by 2 important stitches, what we discussed last time. The most commonly, the one which is performed is actually the McDonald's, where they just take a circular stitch around the cervix at the level of the at the level of the as high as possible in the vaginal fornix, and the knot is tied usually behind. It's just a purse string suture. It's taken submucosally. So this is the most common operation performed for cervical incompetence, that is the McDonald's circulage. Chirurgicals is a more complex procedure where they actually open up the cervix. They take an incision on the cervix and take the bites submucosally and then close them together. So this is more technically more challenging, and it takes a longer time as well. But it is more success rate is much higher, 80%, than the McDonald's, and it's used in severely damaged cervices, as not in prophylactic procedures. And other method for the cervical stitch is abdominal. They even do the laparoscopic wise. These are the different pictures showing you how it is done in the abdominal procedure. That is the cervical stitch, abdominal cervical stitch. Another important cause of abortion, as we discussed previously, was antiphospholipid antibody syndrome. It's an autoimmune disorder and most common cause of recurrent abortions. And we have been diagnosing this of late, especially in such patients. And the tests what we do, or the most common antibodies found out in this particular syndrome, is against the lupus anticoagulants. as well as the anti-cardiolipid antibodies and anti-beta-2 glycoprotein antibodies. So we do test for the presence of these antibodies in case of a recurrent abortion patient. So how these antiphospholipid act is that they lead to placental thrombosis, which results in decrease in the blood supply, resulting in PIH, IUGR, and also the fetal loss sometimes. And the small size of the placenta is also a pathognomonic feature in this particular syndrome. So this is how the pathophysiology of antiphospholipid antibodies. Then there are certain criteria for the diagnosis. One is vascular thrombosis, and then pregnancy morbidity in the form of either unexplained deaths, premature births, or even recurrent miscarriages are important diagnostic criteria. And as we discussed, laboratory criteria for the diagnosis is the presence of lupus anticoagulants, as well as anti-cardiolipin antibodies, IgG or IgM isotype, and anti-beta-2 glycoprotein 1 antibodies. So important point to remember here in antiphospholipid antibody syndrome is the management. We give low dose aspirin, that is 81 milligram daily as a prophylaxis. And once the pregnancy is diagnosed, in a patient with documented antiphospholipid antibody syndrome, we straight away start with low molecular weight heparin once the pregnancy is diagnosed with the UPT is positive and the cardiac activity has been documented on the ultrasonography. So this is a very important point you need to remember for the management of antiphospholipid antibody syndrome. Right. So today we'll continue more about the abortion. But previous class we have studied about the spontaneous abortions. Now we will cover about the what you call as deliberate abortions or the medical terminations of pregnancy, or it's in short, it is also called as MTP. So previously we studied about the spontaneous abortions, but let us now study about the medical termination of pregnancy. So students, you are all able to hear me properly and see the screen, right? So there is no technical issue. I'll admit a few of the students who want to be here. Meanwhile, hello. Yeah, please respond, so that I can understand that you are all there with me. Shall I continue?
Yes, ma'am.
Yes, ma'am.
Fine, thank you so much. So continuing with the class, today we'll discuss about the medical termination of pregnancy. Now, the medical termination of the pregnancy is bounded by a law in India, and it is legal in India. What you have to remember, it is legalized in India by an act that is called as the MTP or the Act, or the Medical Termination of Pregnancy Act. There are many countries in the world where the MTP is still not legalized, and they do not extend the services for MTP. So whereas India, and we should say that the citizens of India are fortunate that it is legalized, and therefore any woman can seek MTP if there has been an unwanted pregnancy legally, and she will be able to get a proper treatment for it. So it is bounded by the MTP law or the Act of 1971, and it was passed in August 1971 and came into effect from April 1972. It extends to the whole of India except the state of Jammu and Kashmir. Now, the MTP Act and the important points in it is very important for you all to remember. It can be a main question and even a short note, and there are various procedures involved in MTP, which might be, you might get as short notes as well. So it is very important. Now, coming to the different aspects of the MTP Act, indications, first of all, like when are you legally eligible to offer an MTP to the woman? Now, there are different indications that have been classified. First one is therapeutic. Therapeutic is when the continuation of the pregnancy endangers the life of the woman or may cause serious injury to her physical or mental health. So this could be when the mother is having some medical problems, or even she might have some psychiatric illness. And then if at all there has been an unwanted pregnancy, it can be terminated under this clause. Eugenic is when there is risk of the child being born with serious physical or mental abnormalities. This may occur if the pregnant woman in the first 3 months suffers from German measles, like there is an incidence of congenital defects to about 10 to 12%, smallpox or chickenpox, toxoplasmosis, viral hepatitis, or any severe viral infection, or if the pregnant woman has been treated with any teratogenic drugs like thalidomide, cortisone, aminopterin, antimitotic drugs, or even if she consumes hallucinogens or antidepressants, or when the mother is treated by X-rays or radioisotopes, and if there is an insanity of the parents. So these factors will be classified into eugenic factors, and whenever there is a risk of a child being born with mental or physical abnormalities, the MTP can be offered. C is on humanitarian grounds when the pregnancy has been caused by rape. D is social when the pregnancy has resulted from a failure of contraceptive methods in case of a married woman, which is likely to cause serious injury to her mental health. When social or economic environment, actual or reasonable expected, can injure the mother's health. So these are some of the indications for the termination of the pregnancy. Rules are when and where you can terminate the MTP again have been guidelined. These guidelines are present within the Act. So the rules are only a qualified registered medical practitioner possessing a prescribed experience can terminate the pregnancy. Chief Medical Officer of the district is empowered to certify that a doctor has the necessary training to do abortions. A medical practitioner can qualify if she has assisted in performance of 25 cases of MTP in a recognized hospital. The pregnancy should be terminated in government hospitals or in the hospitals recognized by the government for this purpose. Non-governmental institutions may take up abortion if they obtain a license from the chief medical officer of the district. The consent of the woman is required before conducting any abortion. The written consent of the guardian is required if the woman is a minor, that is less than in cases of less than 1%. Now, with all this, you need to understand that any person who has to offer a medical abortion or can legally do it is only a registered medical practitioner, and that too, the person has to be trained, and always we have to take permission from the chief medical officers, and in our case it is the district head of district health officer or the DHO, he who is heading the district health system. We all have to apply to the DHO as to provide a license, not only for the person to be registered to provide the MTPs, also we have to register our place, that is where if it's a government hospital, then we need not have a permission. It is by the law that it can be used for the abortions. But if it's a non-government, then we need to apply permission to the DHO's office and submit certain documents which they require, especially the qualifications of the person doing, as well as the place availability with the facilities, like at the OT facilities, the labor facilities, etc., have to be mentioned. And once they check that all these criteria are fulfilled, then the district health officer will give a license or a certificate to allow the particular place to be used for MTP services. So these are the different rules which are applied for the MTP. Now, other important points what you have to remember is abortion cannot be performed on request of the husband. It is only the woman herself. Okay, that only the woman's consent is more important if she's married or if she's a major. Even if she's not married, if she's a major, it's just the woman's consent is enough for the performance of the procedure. Another way around, if the woman is not willing on the request of the husband, we cannot terminate the pregnancy. That's an important point to remember. Now, the woman need not produce the proof of her age. The statement of the woman that she is over 18 years of age itself is accepted. It is enough for the woman to state that she was raped, and it is not necessary that a complaint was lodged with the police. Now, regarding this particular statement, this is quite an old statement, and now there has been a lot of amendment in relation to the POSCO law, where the POSCO is a law which deals with the sexual atrocities on women, including rape and other things. So whenever there has been a suspected woman pregnant with a suspected rape or a sexual atrocity, then we need to inform the police whatever the problem is, either in a government institute or in a non-government institute, it is important that we report it to the police right now. So this statement doesn't good hold right now. Earlier it was so. Professional secrecy has to be maintained, of course. The admission register for the termination of pregnancy is secret document, and the information contained therein should not be disclosed to any person. If the period of pregnancy is below 12 weeks, it can be terminated on the opinion of a single doctor. But if the period of pregnancy is more than 12, between 12 to 20 weeks, two doctors must agree that there is an indication for the medical termination of pregnancy, and two doctors' consultation has to be documented before you start terminating the pregnancy. So this is a very important point you need to remember. Once the opinion is formed, the termination can be done by any one doctor. Termination is permitted up to 20 weeks of pregnancy in legally in India. In an emergency, pregnancy can be terminated by a single doctor even without required training, even after the 20 weeks pregnancy, without consulting a second doctor in a private hospital which is not recognized. This is only in case of emergency, when the patient is already coming to you in a state of inevitable abortion in an emergency without prior consultations. Then you can still go ahead with the procedure, because you need to save the life of the patient at that moment of time, and later on you can report the incident to the concerned authorities. The termination of the pregnancy pregnancy by a person who is not registered medical practitioner or in an unrecognized hospital shall be punished with rigorous imprisonment for a term which shall not be less than 2 years, but which may extend to even 7 years sometimes. So coming to the methods of termination of methods used for performing the MTP, there are different methods for first trimester and second trimester. So in the first trimester, we can offer medical methods or surgical methods. In the medical methods, there are different combination of tablets which are used and tried. They include mifepristone, which is also called as RU486. It is an anti-progesterone chemical content. Then we have a combination of mifepristone and misoprostol. We have methotrexate and misoprostol, and tamoxifen and misoprostol. So these are various combinations of medical combination of drugs which are used for medical MTPs in the first trimester of pregnancy. Surgical methods for the first trimester include menstrual regulation, vacuum aspiration, which is also either MVA, that is manual vacuum aspiration, or EVA, that is electronic vacuum aspiration, suction evacuation and or curettage, dilatation and evacuation, which is again a rapid method or a slow method. So these are the different methods used for termination of the pregnancy in the first trimester. In the second trimester, that is between 13 to 20 weeks, the medical or the drugs which are used for termination include prostaglandins mainly, that is PGE1, that is misoprostol, 15-methyl PGF2 alpha or the carboprost is also used, and PGE2, that is dinoprostone gel, comes in the form of gel, can also be used for ripening of the cervix and termination, and also their analogs. So these are either used intravaginally, that is the dinoprostone, or misoprostol can be used intravaginally. Carboprost comes in the form of injection and it's given only intramuscular, or the intraamniotically also we can use a misoprostol, or even the dinoprostol gel can be used intraamniotically. Then the other methods for second trimester abortion, like dilatation and evacuation, intrauterine installation of hyperosmotic solutions like intraamniotic hypertonic urea, 40% saline, 20% extraamniotic installation of ethacridine lactate. These are some of the other methods used. Then also the prostaglandins like PGE2 and PGF2 alpha can be used. Oxytocin infusion in a high dose can also be used as a method, along with other methods that can be supplemented along with prostaglandins. Oxytocin infusion can also be used as a supplement. Now, this last thing here is actually hysterotomy. I'm not sure if your people are able to see. It is hysterotomy as a last resort whenever the patient is not responding to these drugs, or if there is a danger to the life of the mother in the form of infection developing in case of long-standing IUDs or missed abortions, or if the patient has ended up with bleeding, like especially in placenta previa. In such cases, we end up doing hysterotomy. It's similar to cesarean section, but it is done in less than 20 weeks gestation. Then it is called as hysterotomy, where again it is an abdominal procedure. Laparotomy is done, and the uterus is cut open and the products evacuated and then sutured back. So this is used as a last method, that is hysterotomy in case of second trimester MTPs or abortions. Now, important points to remember, the most commonly used and FDA approved medical regimen, especially for the first trimester abortions, is a combination of mifepristone and misoprostol. Earlier, they used to use 600 milligrams of mifepristone, that is in the form of 3 tablets. That is, mifepristone comes only in the form of 200 milligram tablet. So earlier, they used to use 600 milligrams of mifepristone together, which was given orally on day 1. And then followed by 2 days later, that is 48 hours later, we give oral misoprostol 400 micrograms tablets on day 3. Now, the important thing what you should remember is this particular regimen can be given only up till 49 days from the start of the last menstrual period. So beyond 49 days of the LMP, it is not approved to be given actually. So this was the earlier protocol, FDA approved, where they would give 600 milligram mifepristone on day 1 and 400 micrograms of misoprostol on day 3. But nowadays, the one which is followed and has been approved again by the FDA is where the dose of the mifepristone is reduced. So what they found in different studies is 200 milligram of mifepristone was as effective as 600 milligram of mifepristone. So that's why we just use 200 milligram of mifepristone now, that is given orally on day 1. Okay, and then 2 days later, what is the change between this and this regimen is that the misoprostol, earlier they were giving only 2 tablets orally, but in this regimen, what we prefer to use is 4 tablets of 200 micrograms of misoprostol. That accounts to total 800 micrograms of misoprostol is given vaginally. So we ask the patient to take 200 milligram mifepristone oral on day 1, followed by vaginal instillation of misoprostol of 4 tablets at a time vaginally, that is again on day 3, that is 48 hours later. Okay, so this is the recent protocol. It's the most commonly used protocol and it is FDA approved as well. Okay, and based on so many studies, it shows that it has the highest efficacy and it can be used up till 63 days of the last menstrual period of the amenorrhea. And it comes in a form of a combi pack, where there are a lot of commercially available packets like the brand names like Unwanted, and so many other brands, and it comes in a combi pack with a 1 tablet of mifepristone and 4 tablets of misoprostol. So totally there are 5 tablets. So whenever you're instructing the woman to follow the particular regimen, always take a consent, even though it is just on OPD basis you're managing. In case of medical methods for the MTP, especially in the first trimester, you need to take a consent in such case. You need to instruct the patient properly as to what kind of regimen has to be followed, and she need to be followed up after 10 to 15 days. We usually ask her to return back so that we do an ultrasonography and confirm that the abortion is complete, and also instruct her for any complications which might develop, like heavy bleeding, severe pain abdomen, or fever or vomiting sometimes. So in such cases, the patient is instructed to immediately report to the hospital. So this is the standard regimen for the medical method used for the first trimester MTPs. So remember, it is up to 63 days now, and there is 1 tablet of 200 mifepristone and 4 tablets of misoprostol. So is it clear for everyone?
Yes, ma'am.
Okay. So proceeding further, mifepristone, how it acts is it's an antiprogestogen mainly, and it blocks the progesterone receptors in the endometrium, and this leads to the disruption of the embryo, production of prostaglandins, as well as decrease in the HCG hormone. So this is how the mifepristone acts in termination of the pregnancy. What are the contraindications of medical abortion with mifepristone and misoprostol? This is a very important list. Remember, ectopic pregnancy. An IUCD in place associated with unwanted pregnancy is a contraindication for medical abortion. We need to go for a surgical method in such cases. Chronic adrenal failure, concurrent long-term corticosteroid therapy, history of allergy to mifepristone or misoprostol, severe anemia, coagulopathy or anticoagulant use, active liver disease, uncontrolled seizure disorders, cardiovascular disorders, and relative contraindication is a form of a renal disease. So these are contraindications for use of this kit, that is mifepristone and the misoprostol combination. The next method available for termination, especially in the first trimester, is suction evacuation. It is most suitable method for first trimester abortions from 7 weeks to 15 weeks. It is done under local or paracervical block, but in our practice day to day, most of the times we use a short GA, and always an anesthetist is involved in the procedure, especially where available. Local anesthesia and paracervical block, some people still practice in the level of PHCs where an anesthetist is not available, but in the institutes as well as in the private practice, the practices that we use of we involve the anesthetist, and short general anesthesia is preferred for such procedures. The cervical os is first dilated using Higa's dilators, and then instrument used for evacuation is either a Karman section cannula if it is an early pregnancy, or diameter of the section cannula should be equal to the weeks of gestation. This is just a thumb rule to use up till how much the cervix to be dilated and which cannula to be used. It is just the thumb rule which mentions in this statement that is the diameter of the section cannula should be equal to the weeks of gestation. That means if the gestational week or the gestational age is 7 weeks, then what we need to take or dilate the cervix up to is up till 7 mm diameter of the suction cannula. So that's how is the statement meant for. Now, suction pressure is 60 to 70 centimeters of mercury, and the end point of suction is denoted by. So these are the important points which will suggest that the abortion procedure is complete, and then you have to stop or abandon the procedure. So which are those points? One is no more material is sucked out. Gripping of the cannula can be felt, by the person who's doing the procedure by contracting the smaller uterus. Grating sensation is felt along the walls of the uterus. That's a typical sensation which one can feel. With experience, you will be able to feel these. So grating sensation being felt shows that there is no more soft, friable products along the uterine walls, and it's just the normal endometrium and the the normal uterine wall what we are feeling with the grating sensation. And appearance of the bubbles in the cannula once the air starts flowing within the uterine cavity, and when we try to do the to and fro motion along with the cannula, you see some air bubbles coming out. So these are the 4 important points which indicate that the procedure is complete and there is no more product left inside, because as you can see, this suction evacuation is actually a blind procedure. We are just able to feel it with our hands rather than actually we are not seeing the uterine cavity there and then trying to evacuate. So earlier these used to be the signs as to telling us that the procedure is complete and there is no more retained products left. But nowadays, with the advantage of having an ultrasonography, what we do is we use the ultrasonography machine in the intraoperative period, and if possible, if radiologist is available, fine. If not, we ourselves can do the scanning intraoperatively and confirm that there is no more product left in the uterine cavity, and then we can complete and stop the procedure with confidence. So earlier it was like a blind procedure, as I told, where we couldn't see actually and only kind of feel that the procedure is complete with these kind of indirect signs, whereas now we can actually document by doing an ultrasonography in the intraoperative time as well. Whatever said and done, whenever there has been a suction evacuation, we always confirm that the procedure is complete by documenting an ultrasonography either the next day or the same day before discharging the patient. So that's very important. Now, advantages of suction evacuation is it is done as an outpatient procedure. when it is done under like local anesthesia, general anesthesia, we usually discharge the patient within a day. The low failure rate of less than 1%. Complications like incomplete evacuation, infection, uterine perforation, and excessive bleeding are there, but they are quite rare. There is about less than 2% when we take all precautions like an experienced person doing the procedure, and we take adequate cover of antibiotics and take all safety precautions, then we can avoid these complications. Mortality is 2%. Note, injury by section evacuation is more dangerous than by Hegar's dilators. So if the injury is by dilator, we have to, what is the recommended approach is you can just wait and watch. If you feel that you have injured the cervix by dilator, it is still okay. You can just wait and watch. But when there is a suspicion that you have injured by suctioning, then you definitely have to check up with a laparotomy, laparoscopy, after, of course, an ultrasonography, because the damage to the uterine wall, that is perforation by the suction cannula, and then, of course, when you use a suction, there are more likely chances of actually injuring the bowel and other structures in the abdominal cavity. And that's why always, whenever you suspect an injury by a suction cannula, you have to end up doing laparotomy and laparoscopy. Whereas if you suspect an injury with just the dilator, where you can expect just the maximum is just a small perforation or injury to the cervix, you can still wait and watch and observe the patient for any problems occurring in future. So this is what the two important points you need to remember. Now, menstrual regulation. There is a difference between suction evacuation and menstrual regulation. Remember, menstrual regulation is done by a cannula that is called as the Carmen's cannula, and it's also a plastic cannula. It just consists of aspiration of contents of the uterine cavity, and a plastic 50 cc syringe is used attached along to the Carmen's cannula. It is carried out effectively within 14 days of the missed period. So remember, within 14 days of the missed period is like up till 6 weeks of pregnancy. You can go ahead with the menstrual regulation with the Carmen's cannula, but not beyond that. Beyond that, the indicated procedure will be a suction evacuation, as we discussed. Now, a paracervical block or a preoperative sedative alone suffices, but sometimes apprehensive patients GI is required. Blood loss is very less, and it is included in the methods of performing MTP. Manual vacuum aspiration is done up till 12 weeks. A 60 ml syringe is used here, and a 60 mm of mercury pressure is generated when we use this particular MVA, which is short term. And it is important to note that after 15 weeks, best method of MTP is by using oxytocin followed by prostaglandin drugs rather than any of these surgical procedures. So remember the difference between Carmen's cannula and manual vacuum aspiration. It is just a 50 cc plastic syringe, whereas is a 60 cc proper instrument. We can just see in the next pictures here. This is the Carmen's cannula. It's just a syringe like a thing, and these are the different cannulae, what you can see. Whereas this is whole set of manual vacuum aspiration. You can see here, this is a 60 cc bigger syringe. It has two valves in the front here, as you can see. These valves, when we close it up, what we do is we close the valves and pull up the syringe out so that the vacuum is generated. And then we insert these cannulas. All these are plastic cannulae, what you can see earlier. Nowadays, we absolutely don't use the steel cannulae, which was used earlier for the MTP. Only the steel Hegar's dilators are used to dilate the cervix. Subsequently, we use only plastic cannulae so that the injury is lesser. Both in manual vacuum aspiration as well as even in suction evacuation, we use these plastic cannulae only. So what is done here in the manual vacuum aspiration is the cannula is inserted on the tip here, and we press these two valves, as you can see, and pull up the syringe out, and a vacuum is created. And once we insert the cannula within the uterine cavity through the cervix after dilatation, of course, is we release these valves. Okay, we release these valves, and the vacuum, what is generated, will kind of suck all the material within the uterine cavity, and it will be accumulated in this particular syringe, which is transparent. So this is Here, the vacuum is created manually with the help of these valves and the suctioning pressure of the piston. Whereas in suction evacuation, we actually attach these cannula to a rubber tube and then the electronic suction machine. So that is suction evacuation, and this is manual vacuum aspiration. So it's all clear to all of you? There's no confusion?
Yes, ma'am.
Did you understand what is the difference between Carman's cannula and manual vacuum aspiration?
Yes, ma'am.
Yes, any doubts? So you can see here, this is actually the Carman's syringe, and the cannula will be usually same, just as a one valve, and it's smaller than the manual vacuum aspiration. This one has a two valves here. Clear? So with this, we come to the end of the small explanation regarding the medical termination of pregnancy. So now we have covered the spontaneous abortion in the previous class and MTP now, and I hope you're all thorough with the theoretical aspect of these two important topics. We will now go ahead with the MCQs based on these two topics. Fine. So any doubt regards to these topics? If anybody has, please let me know before I proceed to the MCQs. So I'm not getting any answer. Shall I proceed then, students?
Yes, ma'am. Proceed, ma'am. Continue.
Okay. Fine. So beginning with the first question. The most common cause of first trimester abortion is chromosomal abnormalities, syphilis, rhesus isoimmunization, or cervical incompetence. These are all very simple and easy answers. I want you to all answer quickly. Chromosomal abnormalities, is it not? So as we discussed, the chromosomal abnormalities are the most common causes of first trimester abortions. Syphilis is not very related. It could cause first or second trimester depending on when the infection occurs. Okay, so it's not particularly related to the trimester. Whenever the patient develops infection, she might end up in abortion either in the first or the second trimester. Now, rhesus isoimmunization, if it has not been recommended only, then the patient will end up in abortion. So it could be usually first or second trimester abortion. So rhesus isoimmunization is again not restricted only to first trimester abortions. Cervical incompetence, you all know that it is the most common cause of second trimester abortions, is it not? Rather than the first trimester abortions. So the answer for this question, as rightly said, is the A. That is, chromosomal abnormalities is the most common cause of first trimester abortions. Next. So as I discussed here, just briefly going through what is abortion. Is any termination of pregnancy before 22 weeks. 15% of all conceptus end in spontaneous abortions. 80% occur before 12 weeks of pregnancy, and 50 to 75% of them are because of chromosomal abnormalities. That is a germplasm defect. Second question, commonest cause of first trimester abortion: monosomy, trisomy, triploidy, or aneuploidy? Anybody with this answer? Yes, students? So all these are chromosomal abnormalities which can lead to abortion. Amongst these causes, which is the most common cause of which is the most common chromosomal abnormality which might lead to first trimester abortion? That is the question here.
Trisomy, option B.
Trisomy, yes. That is, of course, one of the answers. But what you have to remember here is trisomy, triploidy, monosomy. These are all related to, the aberrations in the number of the chromosomes. Okay. Whereas aneuploidy is in the problem is with the structure of the chromosomes. Do you understand?
Yes, ma'am.
Did you understand this?
Yes, ma'am.
So when we read the theoretical part, We understood that, of course, chromosomal abnormalities are the causes for, most common cause of first trimester abortions. But amongst the chromosomal abnormalities, the most common, common problem which has been found in these abortuses in the fetus is actually the structural problems in the chromosomes rather than the number of the chromosomes. Okay, so that is aneuploidy. So the answer here is actually aneuploidy, because other three are all related to problems in the number of the chromosomes. If you remember, balanced mutations, as we discussed, is actually the most common cause of common chromosomal problems associated with abortions. Aneuploidy is the answer here, not just the trisomy. So the important points again, what you have to recollect here is the most common cause of early miscarriages is aneuploidy. That is a chromosomal anomaly. That is in the structure. Okay. Amongst the aneuploid abortions, autosomal trisomy is the most frequently identified chromosomal anomaly. Trisomies have been identified in abortuses for all except number 1 and 16, 13, 21, and 22, the most common. The single most specific chromosomal abnormality after abortions is monosomy X. So when you go ahead with all these, when you study these particular points, and then when you want to answer, is the commonest cause actually comes to aneuploidy, because all these three will be involving the last answer. So the answer here will be D. Is it clear to all of you?
Yes, ma'am.
Fine. We'll go to the next one. Third question. A lady has recurrent abortions in first trimester with history of autosomal recessive disorder in family. The true statement regarding this is consanguinity may be the cause, complete penetrance is common, affected members in the family, all are correct. Yes, anyone with the answer? Anybody? See, whenever there is you're thinking of an autosomal recessive disorder in the family. Okay, so whenever there is an autosomal recessive disorder in the family and there is a consanguinity history, what happens is the expression of these autosomal recessive disorders in the family will enhance, is it not? The expression will enhance and it will lead to problems like recurrent abortions or even genetic abnormalities in the fetus. So that's why consanguinity may be the cause of particular problem the patient is having with recurrent abortions and with a history of autosomal recessive disorders. So this statement is actually true. The true statement regarding this statement is true, is it not? Consanguinity may be the cause. When two people expression becomes more common, and that's why they result in abnormalities either in the form of recurrent abortions or congenital problems. It's a true statement, is it not? The first one. Coming to the second one, complete penetrance is common. So remember, whenever there is autosomal recessive, complete penetrance has to not, so it cannot be a partial penetrance. So complete penetrance has to occur in an autosomal recessive disorder to be expressing. So this statement is also true. Agreed with me? The third option, that is affected members are in the family, is of course, as we discussed, that consanguinity, because it is in there and it is running in the family, the members in the family will also be affected. So all these three factors are actually, the points are actually true for this particular statement of recurrent abortions with a history of autosomal recessive disorder in the family. So the answer here is D, that is all are correct. So do you agree with me? Is it clear?
Yes, ma'am.
Yeah. Okay. So this is the same points what we discussed in that the options are all true, and therefore here here, autosomal recessive inheritance is the single largest category of Mendelian disorders, and they have the following features. It is the trait does not usually affect the parents, but siblings may show the disease. Okay, so the option C is correct. Siblings may show the disease in 25% of each birth. Consanguinous marriage may be the cause. That is option A is correct. Now, the expression of the defect tends to be more uniform than in autosomal dominant disorders. Therefore, complete penetrance is common. So, onset is frequently early in life. So, in this case, the lady has recurrent abortions and history of autosomal recessive disorders in the family. Therefore, all the features of the autosomal recessive disorders apply to her. Next, again, trisomy 21, monosomy, PGI, that is, remember that it's a PGI question. In the PGI question, more than 2 options may be right. So, trisomy 21, monosomy, trauma or arch incompatibility. Causes for spontaneous abortion in the first trimester. Yes. Trisomy 21 and monosomy is definitely the causes. Do you all agree with me? Both these answers are correct, is it not?
Yes, ma'am.
Because they are the chromosomal abnormalities. Now, we have to select whether option C and D are causes for a first trimester abortion. See, trauma can be the cause for first trimester abortions, whereas RH incompatibility is not so common for first trimester abortions. So all the first three answers are correct for this particular question. That is trisomy 21, monosomy, and trauma. Whereas this is RH incompatibility is not so common cause of first trimester abortions. So the answer here will be A, B, and C. Okay. Now, next question. Most common cause of abortion in first trimester is again defect in the placenta, uterus, embryo, or ovarian cause. It's the same question which is twisted. So we all know that the chromosomal abnormalities is the most common cause of first trimester abortions. So the chromosomal problem or the chromosomal abnormality is in which part? Is it in the placenta, uterus, embryo, or the ovary?
Embryo.
Yes, students? Yes, of course it is embryo, is it not? So there is a defective genetic material or defective genetic fertilization resulting in a chromosomal aberration, or the problem is with the embryo here. So the option here is C, that is embryo. Clear with all of you?
Yes, ma'am.
Right. Next, coming to sixth question. Recurrent abortion in first trimester is most often due to chromosomal abnormalities, uterine anomaly, hormonal disturbance, or infection.
Option A.
Option A, correct. So again, remember chromosomal abnormalities, as we discussed, if there is any genetic abnormality in the parents as well, like autosomal recessive disorders, it might lead to recurrent first trimester abortions. So always chromosomal abnormalities will come first in cause of a normal spontaneous single single or recurrent abortions in the first trimesters. So answer here is chromosomal abnormalities. Infection, the confusion can be between chromosomal abnormalities and infection. Remember, infections are just one-time causes of abortions, and recurrent abortions are unlikely with infection, because if the patient has got infected with any of the infections which would lead to abortion, then in the subsequent phase of a life, she would have developed antibodies for such infection. Okay, and therefore the chances of the recurrent abortion occurring because of infections is very less. So amongst these four questions, you might get confused between chromosomal abnormalities and infection, but remember, they have asked for recurrent abortions here. So in recurrent abortions, infections are not the causes, whereas chromosomal abnormalities are the causes. So the answer here is A. Okay. Now, seventh question is again similar. Recurrent spontaneous abortions are seen in all except torch infections, uterine pathology, herpes infections, balanced paternal translocations, or none of the above. Remember, PGI question, here 2 answers or more can be right answers. Read the question carefully. Recurrent spontaneous abortions are seen in all except. So what they're asking is conditions where there is no recurrent abortions. So you go through the options one by one and anybody can give the answer.
Herpes infection and torch infection.
Yeah, correct. As we discussed, torch, any infection, any maternal infection do not usually cause recurrent abortions, right? So here both the options, that is torch infection and herpes infection, do not cause recurrent abortions, and those two will be the answers because they have asked except. Okay, so whereas uterine pathology in the form of cervical incompetence or a uterine septum or a uterine anomaly can lead to recurrent mid-trimester abortions. And another thing what they have not mentioned is whether it is first trimester or second trimester. So you have to take both into account, right? So uterine pathology usually cause second trimester recurrent abortions. Now balanced paternal translocations are the most common cause of first trimester abortions, and that too they can cause recurrent spontaneous abortions. So these two will be the causes, whereas these two are not. So therefore the answer for this question is A and C. Okay. Now again a similar question. All of the following are known causes of recurrent abortion except torch infections, SLE, RH incompatibility and syphilis. Again the question here is
Torch infection.
Yeah, torch infection will be, of course, one of the options as we discussed previously. There might be SLE will, is definitely a cause of recurrent abortions. You all should remember it is associated with antiphospholipid antibodies, and therefore SLE is a cause of recurrent abortions. RH incompatibility, if it has not been detected and subsequent pregnancies there has been sensitization, then it can lead to recurrent abortions. So SLE and RH incompatibility can lead to recurrent abortions, whereas torch infections and syphilis cannot. So amongst these two, if there is a confusion, always you have to choose the one which is documented well and studied well. Okay, so you have to choose the answer that is A. Torch infections is the one which is not known to cause recurrent abortions. Agreed?
Yes, ma'am.
Fine. Ninth one, now 26 years old lady with a history of recurrent abortion, which of the following investigations you will do to confirm the diagnosis? PT is prothrombin time, bleeding time, anti-Russell Viper venom antibodies, or clot solubility test. Yes, anybody with this answer? Do you all remember how we did study about how to investigate the antiphospholipid antibody syndrome and which are the tests to be done, especially the clotting tests? See, PT and BT, they are all non-specific. They do not actually give rise to specific diagnosis as to rule out any recurrent abortion cause, right? They are non-specific tests. And even clot solubility test. Clot solubility test will only, it's again a non-specific bedside test. So the one which will actually tell us, as the cause of recurrent abortion is to confirm the diagnosis. Read the question properly. It is to confirm the diagnosis. It is always we need to document the antibodies in any autoimmune disorder. Is it not? So the answer here is, correct answer here will be C, is it not? The anti-Russell Viper venom antibodies, if at all the patient has, and doing this test and documenting the presence of antibodies is actually the test which would confirm the diagnosis. Whereas all three tests are non-specific. They will not give us any diagnosis as a particular cause. They will just give us that there could be some derangement in the coagulation profile of the patient. Okay, so the answer here is C. Okay.
Okay, ma'am.
Fine. The next question. Now, recurrent abortion in first trimester. Investigation of choice. Karyotyping, SLE antibody, HIV, torch infection. So again, I remember PGI question, more than two options can be correct here. So What are your answers?
Option A and B.
Correct. So option A and B can be the right answers for this question. Karyotyping, as we discussed, that first trimester abortions, most common cause will be chromosomal abnormalities, and therefore karyotyping is the correct choice of investigation, where we need to rule out any autosomal problems in the parents. And of course, SLE antibodies, again leading to antiphospholipid antibody syndrome, can lead to recurrent abortion. Therefore, these two are important investigations to be done in any patient with a history of recurrent abortions. Okay. So this is the same thing what we discussed. Remember, Torch infections or any other maternal infection does not cause recurrent abortions. Now coming to the next question, in a case of recurrent spontaneous abortion, following investigations is unwanted: hysteroscopy, testing antiphospholipid antibodies, testing for Torch infections, thyroid function tests. It's the same question but twisted. It should be easy for you all to answer. Yes? Unwanted.
Thyroid function.
See, we all discussed all this while, is it not? What is most important, as in the cause which is not going to cause recurrent abortions? It is Torch infections, is it not? So whenever there is a lady coming with recurrent abortions, we need not do or evaluate her for the presence of Torch infections. Understood? So that is what is unwanted. So read the question carefully. It's unwanted. Whereas we want to do hysteroscopy, we want to do antiphospholipid antibodies because of recurrent abortions. Understood? So the confusion could be between Torch and thyroid, but we all know that infections do not cause recurrent abortions. Thyroid, if it is untreated, it might cause, So that's why the answer for this question would be C, Torch infection. Clear?
Yes, ma'am.
Okay. So again, this is a brief about what investigations you should do in case of a recurrent early pregnancy loss. Parental peripheral blood karyotyping with banding technique is very important. Assessment of the intrauterine cavity in terms of office hysteroscopy or a hysterosalpingography is very important, especially in recurrent mid-trimester abortions. A thyroid function test needs to be done, and whenever there is an indication, a serum prolactin level also is to be done. This we do only when there has been a complaint by the patient of galactorrhea, or if the thyroid function tests are abnormal, then we do a prolactin level in such cases. Anti-cardiolipin antibodies, as we discussed, or a PTT or Russell Viper genome testing to rule out any autoimmune disorders. So the antiphospholipid antibody syndrome is the most common. Complete blood counts and platelet counts have to be done routinely. Thrombophilia testing will have to be done, especially if there has been a history of previous thromboembolism in the patient, or a family history is there, especially of protein C or antithrombin deficiencies. We need to do thrombophilia testing for factor V laden mutation, prothrombin gene mutations, or protein S activity, and also assessing the serum homocysteine levels. So these again will form an important profile for investigations in case of recurrent abortions, especially when the patient is giving a history of previous any venous thromboembolic event, either in the form of, it could be a deep venous thrombosis, that is DVT, or it could be a cerebral vascular event in the form of TIA, or a cerebral vascular accident. So these will indicate that the patient, especially young patients, giving a history of such venous thromboembolisms, we have to rule out the genetic causes for any of these coagulation disorders. So according to the ACOG, this is again a world-renowned body, that is American College of Obstetricians and Gynecologists, which this body forms a lot of guidelines, and they have been followed all over the world. So what they recommend, especially in case of recurrent early pregnancy losses, is what is important to be done is, one is parental cytogenetic analysis, that is nothing but karyotyping. and lupus anticoagulant and anticardiolipin antibodies. So they recommend just these two are more important. Any other investigations like even torch infections or anything else, they don't warrant to be done. So these are a set of investigations which are to be done in such patients. I hope it's just a reminder and a revision exercise for you all so that you don't forget this list. And it's very important because a lot of questions are based on these, points. Okay. Next question. A lady presented to your office with a history of recurrent early pregnancy loss. What are the investigations to be ordered? A. VDRL, toxoplasma serology, hemogram blood grouping, rubella screening, or blood sugars? Is anybody with the answer? See, one thing is very easily you can rule out is, as you know, that infections do not cause the recurrent abortions, is it not? So you can cancel off VDRL, you can cancel toxoplasma, and you can cancel
Toxoplasma and rubella.
right?
Option C and D.
Yeah.
Yes,
So
ma'am.
we are left with option C and E. It could be hemogram blood grouping or blood sugars, right? So between these two, which do you think is more appropriate for evaluating a recurrent pregnancy loss?
Hemogram blood grouping.
Yeah, that is correct actually. Hemogram blood grouping is more important because blood sugars, if at all the patient is not giving any history or there has not been any documented evidence that she's been suffering from diabetes or whatever, it's not very really necessary. And you all should remember, well-controlled diabetes mellitus does not usually lead to recurrent abortions. Okay, whereas hemogram and blood grouping will give you certain more information about the cause for the recurrent pregnancy losses, and in such cases we need to do a hemogram and a blood group. So this is the answer for this question. Is it clear to all of you? So it's important how you arrive at the right option as well. You know, it is either you know the answer properly and then you go directly and just tick it off, or if you're confused, then you rule out or negate the possible wrong answers one by one, and then you shortlist one or two and then concentrate on those two and try to answer the correct option. So this is how you can, the two methodologies you can use to go with the right option for the answers. Okay.
Okay.
So this is the same about what we discussed. You all know that VDRL is done for syphilis. Okay. So I hope there is no confusion between those important tests. Next question. A woman with 20 weeks pregnancy presents with bleeding per vaginum. On speculum examination, the os is open, but no products have come out. The diagnosis is missed abortion, incomplete abortion, inevitable abortion, or complete abortion. Yes, anybody with the answer? Yes. See, remember, important thing, signs of abortion. One is there is a bleeding per vaginum, right? So it shows that she is in one form of the abortion or the other. Is it not? So remember that chart where I described the different kinds of clinical abortions and how will you identify them. So the second point what they have given here is that the os is open. Okay. So the os is open. Now, in which of these abortions the os will be open? The bleeding will be there in all the forms of abortion. Though it could be a little altered, like in the missed abortion, there could be a dark colored, scanty bleeding, whereas in other three, there is a fresh bleeding. Okay. So the second point is will help us in differentiating which kind of clinical problem it is. The os is open in which conditions? Is it open in missed abortion? Sorry, it was not clear.
Inevitable. Option C.
Yeah, so it will be open in inevitable abortion, is it not?
Yes, ma'am.
Okay. And other thing, in which condition it will be open? The os will be open in inevitable abortion, right? It will be open in incomplete abortion also. Yes or no? Yes or no, students? The os will be open, is it not, in incomplete abortion? But what is the other feature you will be able to see in incomplete abortion? The os is open and you can actually see some products of conception coming out of the os. Is it not?
Yes, ma'am.
So in this scenario, what they have described is that the os is open, but no products have come out yet. No products have come out, right? So it is not fitting the criteria of incomplete abortion, missed abortion, or complete abortion, right? So our answer here, as we discussed, will be inevitable abortion. So what was the definition of inevitable abortion? It is a process where the abortion has proceeded to the stage where we cannot revert it back. Okay, so when the os is open, we cannot revert it back. So the process of abortion has to be expedited and the products to be expelled or assisted to be expelled. So it's clear with you all. So next question is also similar. It's based on the same kind of a situation. Now I'll read out. A 25 years old female reports in the casualty with history of amenorrhea for 2.5 months and abdominal pain and bleeding per vaginum for 1 day. On examination, the vital parameters and other systems are normal. On speculum examination, bleeding is found to come from the os. On bimanual examination, uterus is of 10 weeks size. Soft and os admits 1 finger. What is the most likely diagnosis? Is it threatened abortion, missed abortion, inevitable abortion, or incomplete abortion? Read the question again properly and so that you can answer it rightly. Just note down what are the points they have mentioned. 2.5 months means how many weeks do you expect? In weeks, it will be how much accounting to? 2.5 months?
8 to 10.
Yeah.
10 weeks.
2.5 is approximately 10 weeks, is it not? And what is the important?
10 weeks.
Yeah.
Yes,
What is the important point you have to note here is that the uterine cycle is
Bleeding.
also 10 weeks. That means it is corresponding to the gestational age what the patient is mentioning. Okay, so that means in case of conditions like in threatened abortion, missed abortion, as well as in inevitable abortion, the uterine size will be corresponding to the size of the gestational age. Is it not?
Yes, ma'am.
Is it in all the three or only two? See, in missed abortion and in incomplete abortion, actually the uterine size will be lesser because in missed abortion, what happens? The fetus is dead inside and it is retained. Okay, so the patient is actually giving you a history of 12 weeks, but the fetus might have been dead from 10 weeks only. So the uterus doesn't grow beyond that and it is dead and it is retained inside itself. So most of the times in missed abortion, it is the size of the uterus will be lesser than the period of gestation what the female is giving you the history. Similarly, in incomplete abortion also, the period of gestation or the size of the uterus will be lesser than the gestational age because in incomplete abortion what would have happened is half or partially the products would have expelled. So once there is expulsion of some products, the size of the uterus will automatically come down, is it not? So in these two conditions, that is missed abortion and incomplete abortion, the size of the uterus will be lesser. Whereas in this particular situation, what they mentioned is the size of the uterus is corresponding to what history she's giving. 2.5 months of history and 10-week size. That means it will be in one of these two situations. Either it is a threatened abortion or an inevitable abortion. Okay. We have narrowed down to 2 options with this particular criteria. Now, next things what would indicate on speculum examination, bleeding is found to come through the os. That's fine. That is not going to help us in any kind of diagnosis. Another important point you have to note here is the os is admitting one finger. Os admitting one finger means the os is open, is it not? So if the os is closed, we won't be able to admit any finger there, not even the tip of the finger. That means the os is closed. Whereas in this case, the os is admitting one finger means it is dilated or it is open. Is it not? So now in these two conditions, between these two conditions, whether it is a threatened abortion or an inevitable abortion, the os will be open in which condition?
Inevitable. Option C, ma'am.
Inevitable abortion. Correct. So I hope there is no confusion between any of these clinical scenarios. You all have understood all this properly?
Yes, ma'am.
Okay. So this is the table again, which is showing all the features of different kinds of abortions we discussed last time only. So I'm not going to go into the details. Now coming to the next question. Now 15th one, a woman with a history of recurrent abortions presents with isolated increase in APTT. That is, it's again a coagulation test. So most likely cause is lupus anticoagulant, factor 7 deficiency, von Willebrand's disease, or hemophilia A. What is the answer here?
Option D.
See, it is isolated increase, means all other coagulation factors are normal. Only the APTT is increased. So this factor 7 deficiency, von Willebrand's and hemophilia, these all
Factor 7.
are coagulation disorders where there is derangement of not only APTT, there is also derangement in the PT, the BT, the clotting time, everything. Okay, so isolated increase is seen only in such cases, that is antiphospholipid antibodies or lupus anticoagulant, especially when there is a presence of a lupus anticoagulant. Okay, clear to all of you? So the answer will be A
Yes,
here.
ma'am.
Okay. Now, antiphospholipid antibody syndrome is associated with all of the following except pancytopenia, recurrent abortions, venous thrombosis, pulmonary hypertension. What is the answer? Now, does it cause pancytopenia, antiphospholipid antibody syndrome? What is pancytopenia? Yes?
Decrease in RBC, WBC, and platelet. All
Yeah.
cells.
So, is there a
Blood
pancytopenia
cells.
in antiphospholipid syndrome? The patients are hale
No,
and healthy
ma'am.
actually. You know, it is very difficult to diagnose just on the hemogram is normal in most of the patients, is it not? So pancytopenia is not a feature of
Yes,
antiphospholipid
ma'am.
antibody syndrome. Whereas recurrent abortions is there, of course, venous thrombosis is actually the pathological problem which is there in these syndrome, and pulmonary hypertension does exist in case of severe antiphospholipid antibody syndrome, where the pulmonary vessels getting affected will result in pulmonary hypertension. So all these three features are the features of phospholipid antibody syndrome, whereas pancytopenia is not. So the answer here will be A. Okay. So the pathology basically is the same. In recurrent abortions, there is a thrombosis in the placental bed or the placental blood vessels. So that's why that results in, a decreased placental blood supply to the fetus and the fetal death of the fetus in recurrent abortions. And venous thrombosis, and again, as I explained, pulmonary hypertension because of the thrombosis in the pulmonary vessels. So these three would be the correct options, and this one is not a feature. So the answer here is A, because they've asked except. Okay, clear to all of you?
Ma'am, please.
Next question. All of the following are true about the lupus anticoagulants, except there is an increase in APTT, recurrent second trimester abortions in pregnancy females can occur without other symptoms of antiphospholipid antibody syndrome, severe life-threatening hemorrhage. So again, except here, that means one of the options is not true with regards to lupus anticoagulant. Previous question we discussed that the APTT is increased, is it not?
Yes, ma'am. It is increased.
So that will form a feature of, in lupus anticoagulant. Is it not? That's correct. Recurrent abortions are there? Yes or no?
Yes, ma'am. Yes, ma'am.
So again, this is the part of presence of lupus anticoagulants. Now, it can occur without other symptoms of antiphospholipid antibody syndromes? Yes or no? Yes.
Ma'am.
So all three options are correct. What is
Okay.
wrong or is not present in lupus anticoagulant is it's a severe life-threatening hemorrhage. So it doesn't cause hemorrhage actually. Remember, what it causes, it's the opposite. It causes thrombosis. It causes intravascular thrombosis. So it does not cause hemorrhage. So because it causes intravascular thrombosis, it will lead to all these complications. Right? So remember, the last one is a wrong answer or the wrong option for this particular question. Okay. So here this same chart I have introduced to just explain to you the clinical features which are seen in the antiphospholipid antibody syndrome. And remember, it is most often because of the thrombosis rather than venous thrombosis rather than hemorrhage. So venous thrombosis leads to all these complications like DVT, even cerebral vascular thrombosis. Arterial thrombosis is less common. Pregnancy complications are again because of the thrombosis in the placental bed, which will lead to abortions, preeclampsia, eclampsia, placental insufficiency and abruption. Postpartum complications like pulmonary infiltrates, fever and cardiac symptoms is again a possible problems caused by this particular syndrome. Okay. Now, next question. Cervical incompetence is characterized by first trimester abortion, second trimester abortion, premature rupture of membranes or cerclage operation is done. This is a PGI question. Remember, there could be multiple correct answers here. Yes, students? Is it a first trimester abortion, cervical incompetence? It's a very easy question.
No.
So this is not the right answer, is it not? Whereas second trimester abortion, yes or no? Is there a premature rupture of membranes in case of cervical incompetence? Yes, because typically in case of cervical incompetence, what happens is because the os opens, the membranes will herniate. Okay, so the membranes will sag down. They will herniate and the form of funneling. The os will be funneled and therefore the membranes will come down. And since the membranes are exposed to the exterior, they end up in rupture. Okay, so typical feature when the patient is coming to you in second trimester abortion because of the cervical incompetence, she'll come with painless rupture of the membranes with a leak, history of leak and sudden expulsion of the products of conception like the fetus and the placenta. So this is a typical history what the patient will give you in case of cervical incompetence. So therefore, premature rupture of the membranes will be a very common feature in case of cervical incompetence. As I told, it is because the os is open, the membranes get herniated and there is no support and they're exposed to the outside and result in rupture of the membranes. Okay. So this is again an important feature in case of cervical incompetence. Of course, last one option you all should be agreeing, cerclage operation is done for cervical incompetence. Yes or no?
Yes, ma'am.
So the answer here is A. Next, in cervical incompetence, encerclage operation done are McDonald operation, Shirodkar operation, Purandare's operation, Khanna sling operation and abdominal sling operation.
Option A and B.
Option A and B, correct. Because all others are done for what procedure or what gynecological problem are these operations done for? Yes? They're all done for prolapse of the uterus, is it not? So in a prolapse of the uterus, especially in a
Yes,
young
ma'am.
female where you don't want to go ahead with the hysterectomy or the vaginal hysterectomies, you want to save the uterus for her fertility, you just do these sling operations to pull up the uterus and hold it by some sort of sling which is attached to the abdominal wall or the pelvic wall through some muslin tape or something like that. So these three operations are done for prolapse, whereas McDonald's and Shirotkas are done for cervical incompetence. Next, a Gravida 3 female with history of 2 previous second trimester abortion presents at 22 weeks of gestation with funneling of cervix. Most appropriate management would be administer dinoprostone and bed rest, administer misoprostol and bed rest, apply Fothergill stitch, or apply McDonald stitch. Gravida 3 with 2 previous second trimester abortion, now she's presenting at 22 weeks to you. And they have mentioned there is a funneling of the cervix. What would you do in such case? Yes? Would you like to go ahead and see that, she will retain the pregnancy or no? See, administering dinoprostone, administering misoprostol, when do you do? When you want to terminate the pregnancy. Is it not? Bed rest and dinoprostone, misoprostol don't go hand in hand. Now, there are two thoughts of management here. Like either you want to terminate it, it is in the process of an inevitable abortion where you cannot hold on the pregnancy and you have to terminate, or you can still salvage the pregnancy with some emergency procedures. Is it not in this case? So here what the options they have given is dinoprostone is nothing but a prostaglandin E2 gel, that is a cerviprime gel, what we use for actually induction of labor or the medical termination of pregnancy. We just discussed it previously, is it not? Misoprostol is also used for termination of the pregnancy only. So these two options there, what they've given is for the termination of the pregnancy. Now third option, that is Fothergill stitch. Where is this Fothergill stitch used? Anybody? It's also called as Fothergill's operation or even Manchester operation. Where is it used? Anybody? Yes? Students, are you all there? If I don't get a response, I feel like I'm all alone here. Yeah. So where is this Fothergill's operation done? In which condition? It's done in prolapse of the uterus. Okay, especially where there is a prolapse because of an elongated cervix. So what they do in this procedure, in Fothergill's procedure, is they amputate the cervix and then stitch over the vaginal mucosa over that. Okay, so that is Fothergill's operation is done for prolapse of the uterus. So it doesn't is not at all relevant for this particular scenario. So this option is absolutely ruled out, right? Okay, see, now this patient is coming to you with previous 2 history of second trimester abortions. Though the cervix is funneling, she is coming to you at the right time, 22 weeks. Okay, we can still try to salvage this pregnancy by doing an emergency stitch. A McDonald stitch can still be applied to her and we can, try to save her pregnancy as much as possible. In spite of putting up the stitch, still she proceeds to abortion, it is definitely not in our hands. But at this stage, we can still try and put a stitch to her. Understood? Rather than going ahead directly with termination with these two options. Is it not? So,
Yes,
what they
ma'am.
have asked is the most appropriate management for this patient. Most appropriate is we would still go ahead and try to salvage a pregnancy by putting up a stitch first rather than directly going for termination. So the answer here, the right will be D, that is applying a McDonald's stitch. So is it all is it clear with you all? You don't have any doubt, is it not, with this particular option?
Clear, ma'am.
Yeah.
Clear, ma'am.
Okay, fine. So this picture was, I just put it up here to explain to you what do you mean by Fothergill's, if you all were, interested as to what kind of procedure is that. So Fothergill's is vaginally done, where what they do is the cervical length is elongated here. So the cervix normally, if it's about 3.5 to 4.5 centimeters, in such patients, it will be like 6 to 7 centimeters. Okay, so what they do is they amputate the cervix. They cut the cervix here. First, they open, of course, the vaginal walls in the fornices, and they tie the posterior vaginal fold to the cervix from inside out, and also anteriorly also. And these two tags, what you can see here, is actually the cut ends of the McEnroth's ligament. Okay, so they pull the McEnroth's ligaments, cut them, and they tie on the sides first to the cervix. They adhere or they hold the cervix with the help of these McEnroth's ligaments, so that will form a good support as well. And then they cover the raw area of the cervix with the posterior vaginal wall and the anterior vaginal fold like this. So this is actually Fothergill's procedure, which is done for prolapse of the uterus, especially with the elongated cervix. Clear to all of you?
Yes, ma'am.
So next question, McDonald's stitch is applied in the following conditions, except incompetent or septate uterus, placenta previa, or bad obstetrical history. Answer, the question here is except, remember. That means it is done in which procedures and it is not done in which condition. Is it done in incompetent us or no?
Yes, ma'am.
It is done, of course. Second option, is it done in septate uterus?
Yes, ma'am.
Yes. What about placenta previa? In placenta previa, you do McDonald's stitch?
No, ma'am.
No, it is contraindicated. Remember, when placenta previa is there, it means that it is on the os or it is on the just in the cervix. So it is always risky through a McDonald's stitch in such a situation. We do not do placenta stitch or McDonald's stitch in placenta previa because there are very high chances of injuring the placenta. So it is contraindicated. Whereas in bad obstetric history is nothing but it could be either recurrent abortions or even recurrent fetal demises, loss of fetuses. So bad obstetric history is an option where you go ahead with a McDonald's stitch whenever there has been a second trimester abortions. So all the three are options, right options, whereas placenta previa is a condition where we do not do that. So the answer for this question will be C. Agreed? So extending that one, what are the contraindications for cerclage operation? Remember, any intrauterine infection, ruptured membranes, history of vaginal bleeding, which could indicate placenta previa, then severe uterine irritability and cervical dilatation if it is more than 4 centimeters. These are the conditions where the cerclage operation is not indicated or we cannot do it. Okay. So students, I think I'll stop here. We are completed like today's session. There are a lot of more questions coming up on the same topic and we'll cover it up in the next class in the third part of it. Okay.
Okay, ma'am.
Fine. So today we did most of the questions on the first trimester abortion and second trimester abortion. We covered up, topics like chromosomal abnormalities. We revised the clinical scenarios of different abortions. We also revised on the antiphospholipid antibody syndrome and also the cervical incompetence as the causes for abortion. And we addressed the questions related to those. So in the next class, we'll continue with the similar questions on this topic. So meanwhile, if you all can please let me know if there is any doubt or any concern, you can please discuss with me. Yes, students? Fine. If there is no any point to be discussed, I would like to end this class here, and thank you all so much for attending, and hope to see you in the next session as well, where we continue on the same topic. So anything related to any other topic in the OBG, you can always get in touch with me in the group or on the WhatsApp number. So thank you all very much, and have a good evening and good night.
Ma'am.